morning, everyone. Good morning. I'm glad you're able to join us. It may be rainy outside, but it's sunshine in all of our hearts. So we are so glad that you are able to join us for our first Health Equity Diversity Leadership Impact Series. Wow, are you in for a treat? But before we start, I just want to say good morning to all of our community partners that are joining. I know it's a lot of you out there. I know we have our legislators out there. I know we have our healthcare workers. Great shout out, our practitioners, our students, our educators. We got our seniors out there, and we got so many others. So we are glad to have all of you here today, and we thank you for joining us. The purpose of this series is to address issues facing our communities of color, more specifically, those issues of inequality that have impacted our communities, specifically during the pandemic. You know, today's webinar, Build Trust in Equity and Science. It's being held during the month of April. You know, April is National Minority Health Month. And this year we are highlighting the role of individuals and organizations and the roles that they really play in helping us to address issues of inequality. Our program today is being hosted by the New Jersey Legislative Black Caucus Foundation, a nonprofit corporation that is created for the purpose of promoting public policy by encouraging the interactions of community with legislators and members of government at all levels. There are so many things that they're addressing. They provide scholarships and internships. They're sponsoring seminars to educate the community on legislative policy, and so many other things that you'll hear about during some of the other virtual webinars that you'll have a chance to be a part of. I also want to just say thank you because our sponsors, and you'll probably hear that more so throughout the program, our sponsors here, we could not do this without us being collectively working on things together. We are partnering, and we're partnering with none other than Bristol Myers Squibb. We thank you for being in the forefront of helping us with this, in partnership with Rutgers University, Montclair State University, and of course, the state, New Jersey, acts for us. We thank you all for being here, but most of all, we want to get to this dynamic panel of experts that you will be hearing from. But before we get to them, I have to introduce you to one of our, what I call one of our forceful leaders. And you're going to hear from a couple of the leaders, but I really want you to hear from this forceful leader. She is and was elected first as the first African-American Assembly woman for the 31st District of New Jersey and the legislature in 2015. She's now currently serving her fourth term. She's a lawmaker that really takes her work so seriously that she has embodied this work as part of her living experience. This is what she does. It's her passion. It's what she does, which she lives every day. So when I think about the work that she's doing, how she's connected, she is a member of the General Assembly in so many ways because she is the chairperson on Aging and Senior Services. She's the vice chair of the Women and Children Committee, and she's a member of Homeland Security and the State Preparedness Committee. In addition, she is the Deputy Majority Leader of the Assembly. You see, she's on her way to bigger and better things. She's doing so much connecting. She's definitely making a difference, not just in the legislature, but definitely on her hometown, in the community, and statewide. When I think about her as an activist and a social advocate, I think about the work that she's doing while she has been an advocate for senior citizens for years. She has done that work. I think about her work more so, and I think about her spirit of saying that her work is from the womb to the tomb. She is one that knows health. She lives it. She is one that lives for doing for her community, for doing for the state of New Jersey. She is caring, she is compassionate, and she is a fierce leader. And I am so proud to introduce her as the chair of the New Jersey Legislative Black Caucus Foundation, but also as one of our assembly people in the state of New Jersey, Assemblywoman Angela McKnight.
Good morning. Good morning. Thank you so much, Dr. Hill, for that beautiful introduction. I appreciate you, and I appreciate everyone who is with us today. We could not have done this without you and our wonderful sponsors that Dr. Hill has eloquently announced. I would love for you just to put in the chat, how are you feeling about today's event? Just put one word about how you're feeling while I continue to welcome you. And the reason why I'm asking you to do that is because we want this to be engaging. We want this to be informative and educational. And yes, we are not together, but in face-to-face, but we are together on this Zoom. So I thank you. And I see all the things that you all are putting in and how you're feeling. So I appreciate you. I am here today to let you know how important this event is. We have struggled for so long and we continue to struggle. However, together we are fighting the struggle. And this series is so important because we have some phenomenal experts who will be on with us to let you know what they're doing in the field and what we all can do collectively. Since COVID-19, pre-COVID-19, we are the 47th state with infant and maternal health. That is crazy that we are 47 and there are only 50 states here. We have to protect our Black women and our Black and brown babies. And this is why we're here. And then when COVID-19 came, oh my gosh, we saw the less equity in our community. This is why it's so important that we hear from experts and we work together so that we can put this to rest. We need health equity and it's key. So this is not the first and only series that we are going to have. We are going to have more. So we need for you to stay connected. We need for you to make sure that you sign up for our email so that you know what we are going to do and how we're going to do it. So I want to thank you for coming on with us today. And I want to thank you for taking the knowledge that you're going to receive. And I'm going to challenge you. After today's event, I want you to reach out to 10, not 5. I want you to reach out to 10 people to let them know 1 or 2 things that you learned today, and then have them to sign up and connect with us on Twitter and Facebook. And we're putting all this information in the chat. And tell them why you're here. And also, you can go on your Facebook page or all your other pages and just let them know what you're doing now so that they can know that you are going to give them some information after you leave here today. So I want to now introduce our fierce leader, Assemblywoman Shawanda Sumter. Now, let me tell you about this woman. I had the privilege to meet her back in 2016 when I became elected, but she has been in the New Jersey General Assembly since 2012. She has served in the executive leadership as Deputy Speaker and Majority Conference Leader. She is representing the 35th Legislative District, that's parts of Bergen and Passaic County. She is our Madam Chair for the Community Development and Affairs. She's also on the Commerce and Economic Development and the Labor Committee. She is a fierce leader. She fights for justice, for equity, for health, for voting rights. She is a leader in getting a reparation task force for us. And I look up to her. She is a sister friend. She is a mentor to me, and she is our chair for the New Jersey Legislative Black Caucus. So without further ado, Madam Chairwoman Sumter, I will love to pass the baton over to you.
Thank you, Assemblywoman McKnight, for that warm welcome. Thank you truly for each of you joining us. I'm Assemblywoman Shawanda Sumter, hailing from the 35th District, also chair of the New Jersey Legislative Black Caucus. To our partners, Thank you. You have valued the idea of hosting this virtual session today with some expert panelists who are doing remarkable work to amplify health equity and diversity. I'd like to give a special thanks to the Honorable Adam Talaferro, who worked with me previously in the state legislature and who is a partner at Bristol-Myers Squibb. Thank you, Adam, for embracing our efforts and leading in this space and connecting us to BMS. In the state of New Jersey, we are currently in the midst of budget hearings concerning a $49 billion budget. It is crucial that we address the budget with the lens of equity. A few weeks ago, Governor Murphy gave a detailed account of the accomplishments of last year's budget, which responded to the social responsibility of necessities and achieved fiscal responsibility to fund our debts whilst easing the burden of future generations. The budget proposal included a wide range of efforts to address health issues exacerbated by the pandemic and to expand social service programs while making critical care more affordable. It is no secret that the effects of the pandemic disproportionately impacted lower income New Jerseyans and communities of color. The Legislative Black Caucus, its 20 members, bipartisan, are committed to making New Jersey a healthier state for all, which includes access to healthcare, which is a long-standing priority in our state. The New Jersey Legislative Black Caucus Foundation, thank you for taking up this critical issue. On our panel today, you will hear from healthcare experts in our ecosystem. They are committed to improving the lives of all people and hyper-aware of the inequities facing minorities. Just a little bit of housekeeping. If you have questions, please put them in the Q&A section. We want to be sure that you have an opportunity to hear from this expert panel. So again, if you have questions, please put them in the Q&A section of the Zoom link. So I'd like to start. We have a very, very special guest who was able to join us today. And we are honored to have Dr. Dara Cass, the Health and Human Services Regional Director. Dr. Cass is a graduate of SUNY Downstate College of Medicine in the Kings County Hospital Emergency Medicine Program. She began her career in resident education at Staten Island University Hospital, followed by medical student education at NYU School of Medicine, and most recently was an associate professor of emergency medicine at the Columbia University School of Medicine. A champion for gender equity and the advancement of women in medicine. Dr. Cass' academic work has focused on creating a more equitable workplace for women in medicine. Most recently, she has shifted her focus to policy and public communication in regards to the COVID pandemic. She has focused her communication on the impact of COVID on communities and families, empowering Americans to make informed decisions for themselves and their families. Region 2 is based in New York City and serves New York, New Jersey, U.S. territories in the Caribbean, and several federally recognized tribal territories. We would like to welcome Dr. Cass, our Region 2 Director. Dr. Cass.
Thank you so much to the New Jersey Black Legislative Caucus Foundation and to Assemblywoman Sumter for that invitation and introduction. On behalf of the Department of Health and Human Services and Secretary Javier Becerra, I will only take a couple of minutes to give remarks to you today. Serving as the regional director for this region is an incredible honor, especially with my background as an emergency medicine physician. I've seen what works in our healthcare system and what doesn't. I know that good government matters and the work we do can save lives. This administration's foremost priority is to improve the health outcomes for all Americans, and it's central to every decision that we make. To do that, we're focusing on a few key areas. I'm going to go through them briefly, and they'll really, I think, echo a lot of the conversation we're going to have today. Our work includes addressing the COVID-19 pandemic, reducing maternal mortality, increasing healthcare access and affordability, and improving health equity while also addressing the mental health crisis in front of us. In terms of COVID-19, we know, we can feel it. We've reached a different time in this pandemic. 2 years ago, we had very limited ways to protect ourselves from this virus. Now we have a lot of tools like vaccines, treatments, tests, and high quality masks that are available to every American. Over 200 million people are vaccinated against COVID-19, and 2 out of 3 people are boosted. Here in New Jersey, you have done an impressive job getting people vaccinated. I am looking at you, Patterson, and now it's time to get more people boosted. Vaccination, regardless of previous COVID infection, is critical for robust protection. Unvaccinated adults are 7 times more likely to be hospitalized with COVID-19 as compared to those who are vaccinated and boosted. With widespread immunity, the overall risk of severe disease impacting our communities is extremely low. We have highly effective treatments like antiviral pills and monoclonal antibodies that can be given immediately after COVID-19 is diagnosed. These treatments dramatically decrease a person's risk for hospitalization or death. With these advancements, we can move forward and go back to something resembling a normal routine. We can get our schools back open and keep them open while also having our businesses thrive. But we need to remain vigilant so we don't get caught off guard again. We need to focus our efforts on other areas of our collective health and wellness. We need to improve maternal health outcomes and reduce maternal mortality. As a first step in the reduction of this maternal mortality and investment in maternal health, the administration announced over $340 million of awards for the maternal, infant, and early childhood home back visiting program. That was $340 million given to every state. New Jersey got $10 million, the New Jersey Department of Health. I do want to acknowledge the work the New Jersey Department of Health has done over the course of this pandemic in really being a leader in the country in its effort to reduce the inequities that are existing in our healthcare system, and really the work that they have done, getting vaccinations, getting treatments, and getting out there. Maternal health outcomes cannot improve without access to healthcare. We just recently celebrated the 12-year anniversary of the Affordable Care Act. Thanks to the ACA, the uninsured population was reduced by 20 million people between 2010 and 2020. The pandemic has brought to the forefront a host of mental health issues that we are committed to addressing. In particular, this administration continues to work towards ending the opiate epidemic and addressing the mental health crisis facing our young people. We're excited to announce a very new tool coming to reach more people in need. This July, the United States will launch 988, a mental health hotline to strengthen and expand the existing National Suicide Prevention Hotline. It's important to remember that 988 is not just an easy to remember number, but it's a direct connection to compassionate and accessible care and to support those who may be in crisis, whether it's immediate risk of suicidality, increasing risk of suicidal thoughts, or just an emotional healthcare crisis. The 988 code is a first step toward strengthening our crisis intervention care in this country. And it's going to create a universal entry point so that no matter where you live, you can reach a trained crisis counselor and they can help you in that moment. Because equity and access is the core of everything this administration does. Marginalized communities know the consequence of social, structural, economic, and environmental discrimination, conditions that determine somebody's risk of illness, access to care, and life expectancy. We know that minority communities are less likely to have access to quality, affordable healthcare, that Black women are more than 3 times more likely to die due to pregnancy or childbirth complications, that COVID has devastated communities of color, and that mental health and substance use disorders are frequently underdiagnosed and inadequately treated in these communities. The Biden administration is deeply committed to changing this. You have an ally in this administration and in Secretary Becerra who is here to fight for all of you. He believes, as President Biden does, that every American should have equitable access to quality healthcare, and that we need to be creating a more innovative environment for the provision of health and human services. We can't do this without you, our trusted partners, and I look forward to continuing to work with all of you. I am going to end my remarks there, and I really look forward to a meaningful conversation. I'm actually really excited just to sit and listen to the remarkable speakers you've brought to the table. So Assemblywoman Sumter, I'm going to bring it back to you now.
Thank you, Dr. Katz, for that warm introduction and for keeping us in tune with what's happening on the federal level. At this time, I'd like to introduce Micheline Davis. Micheline Davis, she is the President and Chief Executive Officer of National Medical Fellowships Incorporated since May 2020. Davis is named among Modern Healthcare Magazine's top 25 most influential minority leaders in healthcare and Becker's Hospital Review's top 50 African Americans to know in healthcare. The National Association of Health Services Executive awarded her their 2021 Senior Healthcare Executive Award. Micheline, please introduce yourself to our viewers today. Thank you.
Thank you so very much, Assemblywoman. And it is such a distinct honor and a high privilege to be on this panel with these brilliant minds on behalf of the New Jersey Legislative Black Caucus. So thank you for the invitation to have NMF here. Hello, ladies and gentlemen. My name is Micheline Davis, as you heard from that kind and warm introduction. I am the president and CEO of National Medical Fellowships. National Medical Fellowships is one of the very first diversity organizations in the United States of America, founded back in 1946. We provide and ensure that BIPOC, that is Black, Indigenous, persons of color who are underrepresented in medicine have an opportunity to actually attain a medical degree. And so as a result of that, we have been ensuring that there have been Black and brown doctors in this country for the last 75 years. I like to describe it as literally picking up the big boulder on health equity and pushing it up the steep hill of inequality in the hot sun of structural and systemic racism. Desired to truly be here with you, delighted to be able to do so.
Thank you for that. Next, we have with us Patricia May Doikos. She is a doctorate executive director of health equity at Bristol Myers Squibb. Patricia has over 24 years of experience in leadership in transformative corporate philanthropy and corporate social responsibility, product brand and strategic communications, and health equity and social justice from her roles in the company's infectious disease businesses and the Bristol Myers Squibb Foundation. She has developed and led the U.S. and international grant making and public-private partnership programs for global HIV, AIDS, women's health, diabetes, cancer, serious mental illness, cardiovascular disease, immunology, and COVID-19. Welcome, Patricia.
Thank you so much, Assemblywoman Sumter, and so good to be with you all. It's such an energetic group. I wish we could start every day together with this group. I'm very honored to represent BMS here. I'm the Executive Director for Global Health and Health Equity. This is a new role that was created last summer at Bristol Myers Squibb, though built on lots of work that had been going on for several years. And the purpose of my job is really to help our company embed health equity in everything that we do for patients every day. So inclusively and with an equity mindset, discover, develop, and deliver innovative medicines that transform patient lives. But we certainly know that we need partners beyond what we can do to really move the needle and move the boulder up the hill towards true equity for everyone and health justice for everyone as well. So we also focus on what we can do beyond the pill. So driving access to quality healthcare for all, acknowledging that social determinants of health and structural determinants of health are in play, and addressing those through partnerships and support to community-based organizations and faith-based organizations, and really looking to bring together the medical experts and the community experts who know so well how our communities have needs and have expertise that can help change the face of health equity. And the last thing that we do is really look at the structural determinants of health. So work to support anti-discrimination work, anti-racism work as well. So very pleased to be with all of you today. And thank you for the shout out to our own Adam Taliaferro, who is an inspiration to all of us every day at Bristol Myers Squibb. Thank you.
Thank you. Next, we have none other than Dr. Chris T. Purnell, Senior Executive at University Hospital in Newark. She oversees a portfolio that includes population health, strategic planning, community affairs, and the human experience. Of note, her role was created to lead the hospital's first health equity and inclusion strategy in an integrated fashion across multiple business units. Dr. Chris is charismatic and a leading voice in preventive medicine and public health. NJBiz named her a public health hero in 2020. Dr. Purnell.
Thank you so much, Assemblywoman. It's an immense honor to be with everyone this morning. What I do, I call heart work, H-E-A-R-T, and it is the work of ensuring that everyone has the opportunity to achieve their highest level or potential of health. And in the face of systems of oppression, systemic racism, in the face of power imbalances, that must be a forward mission of all stakeholders, a forward mission of all sectors. And I firmly believe and double down that our hospitals should be hubs of racial healing. And oftentimes when we think about healthcare, we think about other forms of healing. Yes, we are pushing ourselves around whole person care. Yes, we are pushing ourselves around holistic care, but we need to put a stake in the ground around becoming a hub of racial healing, because otherwise you can't achieve health equity without centering on issues of justice, and racial justice is paramount among that. So the work that we do at University Hospital as the state's only public academic medical center is ensuring that historically excluded communities, Black and Brown communities, receive high quality, culturally fluent, culturally responsive, safe, and equitable care, and that care is not confined to four walls, but that care is integrated into the communities and neighborhoods where people live. So we're very much concerned with whether through our community and population health team, those social determinants, structural determinants, political determinants, those unjust and unfair barriers that are shaping health and life outcomes, and how we as an anchor institution can model anchor behavior, good anchor behavior, and collaborate, partner, and share power to create environments that support healthy living and that support the achievement of health equity. And the final thing that I would say is that this is everyone's responsibility. And increasingly, we as clinicians, whether we're direct care providers or population-based care, there is an understanding that we cannot look through the lens of individual persons or patients, but we must think about the spectrum of the human experience. So patients, families, communities, and our workforce as a whole, in order to be able to achieve these very aspirational but necessary goals. So I look forward to the conversation today, and I'm just thrilled to be on the panel with such esteemed persons.
Thank you for that. Next, we have Sharon Hanlon, Senior Director, Clinical Trial Engagement and Enrollment at Bristol Myers Squibb. Sharon has been at BMS for more than 20 years and has held clinical operations positions of increasing responsibility from line management to project management across multiple therapeutic areas. Sharon is a nurse by training, and prior to her time in the pharmaceutical industry, she had a career as a critical care nurse, nurse educator, and research nurse coordinator at hospitals in the Philadelphia area. Welcome, Sharon.
Thank you, Assemblywoman Sumter, and really excited to be here and join my colleague Patty on this panel. So just for, I think one of the things from my team's perspective at BMS, what we're really trying to do is focus on health equity and diversity in our clinical trial activities. So looking for ways to really bring the voice of the patients, all patients, into our development activities. So looking for ways to truly simplify and make clinical trials a care option that patients will actually consider. So bringing the opportunity to patients more broadly, working with both community activities, patient advocacy groups, as well as patients themselves, to really ensure that we're reflecting both the epidemiology of the disease as well as the broad swath of patients, ensuring that they have access. I love the comment that was made earlier around access, and that's really something that we'll continue and have been focusing on, both access and awareness. We also work as far as the recruitment activity, so ensuring that we're recruiting patients, bringing the opportunity out to patients more broadly, and looking for ways to be broad in our messaging to ensure that awareness and access. ultimately to improve the healthcare and broadening the opportunity for patients going forward. So really, really happy to be here with you all today and really look forward to the conversation as we touch on this important subject. So thank you very much.
Great, thank you, Sharon. So at this time, we're going to begin our panel discussion. Again, to our viewers, if you have any questions you have of this panel, please put it in the Q&A section. That way we can keep an account of the questions. Putting it in the chat gets lost with all of the chattering. So if you can please put it in the Q&A section. To our panelists, I'm going to read the question and then I'll start with the guided answer by calling on each of you to answer the question respectively. So let's begin. COVID-19 magnified the disparities in every corner of our country, disparity in education, and the disparity in income and health. What are some of the structural issues that must be addressed to begin building a healthcare system that is equitable? And I'd like to start with you, Dr. Purnell, if that's okay.
Sure, excellent. So often prior to the pandemic, myself as a public health and preventive medicine physician, I would find that people spoke about disparities from a very conceptual and academic place. And in talking about disparities, we did not go upstream enough to say succinctly and directly the inequities and systems of oppression that are allowing those disparities to exist. So I believe that we have to confront systemic racism head on, right? So Dr. Cameron Jones really revitalized the field when she consistently put to us as past president of the American Public Health Association to name racism and how it's operating in a system in all of our sectors and our institutions and across multiple structures. So I think we as a society, first and foremost, have to stand up and take that stand through policy, take that stand through practice, take that stand through culture. And then internally within our sectors and across multiple sectors and institutions, we have to look at how distribution of resources, how distribution of power, how access to opportunities really have shaped life outcomes, in addition to shaping health outcomes, in addition to shaping the quality of care that people receive. And so it is that level, I would say, of a very robust, very expansive scan of what's at stake and what's in play is what we'll need to do in order to achieve health equity. So that very much means looking at access to high quality education. That very much looks at access to green spaces, affordable food. That very much looks like transportation. That very much looks like, affordable housing. And these were the same factors that contributed to the increased risk exposure that Black and Brown and Native groups experienced through the pandemic. So it's through that structural lens that we're going to be able to be on an authentic and a transparent trajectory to really begin to achieve health equity.
Great, thank you. Micheline, as you are supporting our future physicians coming in, would you like to add anything to that question?
So I just love the fact that when Dr. Chris Purnell speaks, you actually are hearing the voice of NMF. She is actually an alum of National Medical Fellowships. And so you are welcome to the rest of the country. We brought her to you. I think two things. One, because you know that I come from a background of having served at the largest academic medical center system in the state of New Jersey for nearly 13 years. I think it's really imperative that we also make certain that healthcare systems and hospitals are also examining their policies, their practices, their protocols for the way in which they contribute to the proliferation of structural and systemic racism. Large eds and meds are really interesting entities, but quite frankly, as a part of the way in which they operate, they have the ability to turn on a dime the economic stimulus within the community in which they sit, right? And so for those who have the wherewithal to actually embrace their anchor mission and really utilize their place-based presence in order to address those issues, if in fact they overlay on top of their anchor mission a racial equity lens, we have a real opportunity to take a look at who has been historically marginalized, how have we continued minoritizing them, right? What would it look like if in fact we were to be overtly inclusive in the way in which we locally hire, locally invest, and locally live, how would this actually shape the economies of those systems in which we live? It would really, really impact a great deal. And so I wanted to add that to what my wonderful alum has just said. But in addition to that, as a result of the fact that we also need to ensure that we are recognizing that the answers that we need in order to not just reduce, but to actually eliminate health disparities are actually already within our communities, right? I'm a bishop's daughter. So I grew up with a father who would often say, everything you need is in the house, right? Everything we need is in our communities. And so that's why at NMF, we love the opportunity to go to those communities to say, what do you need? What kind of healthcare? What will that delivery look like? And we know what the scholarship, what the evidence has revealed, right? That Black babies live longer when they have Black doctors. That Latina women live longer when they have Latina doctors. And so why not cultivate a pipeline that comes from the community through the educational system and right back in order to ensure that they have that representation? So I've always said that COVID-19 was not the great equalizer, it was the great magnifier. It magnified the structural inequities for those of us who have been in health equity for years have always known. Assemblywoman, you know I come from a policy background, having served as the chief policy counsel to a prior governor, right? And so we understood that the issue around structural and systemic racism, well, how did that show up? Because now everybody's talking about it, but I keep wanting to make certain that folks understand, well, baby, a lot of this comes from, right, the outlay of systems and laws. We talk now about changing systems and structures, but we have to make certain that we're looking not just at structural and systemic racism, but also at the individual racism of those who are actually in place in order to set up those systems and those structures. So we leave nothing off the table. We want to make certain that we are looking at it all as we are really looking to rebuild, not to return to the new normal, because normal was not normal for any of us, right? But to build the new equitable future that our communities deserve. We need to make sure that we're taking these lessons and putting them together to create the new systems that permit equity across the board.
Awesome. And one of the things we were trying to reveal in this panel, and I'll share this with you, someone texted me offline saying that they are here and they're trying to understand the terminology, because we use these terms and what does it mean and how does it impact us? And I can tell you 5 years ago, we were scared to say racism out loud. And now we're saying it as an empowerment to create the change that we want to see with a vision toward the future. Patty, Sharon, I don't know if you all want to add anything to this question.
Just a couple of things that I would build on those, fabulous comments that have been made already, and picking up on some of the thoughts in them. Certainly, we need more disaggregated data so we can see more clearly what the disparities are, and then to direct resources and prioritize resources for communities. I think that was the big aha for many people with COVID-19, once we started to see the impact on communities of color and rural communities as well. So continuing to build that mindset, and that's always in play and robustly supported to deliver us that data so that we can quickly respond. And also clinic community partnerships that really look at is a strengths-based approach. So as Dr. Davis had said, there's so much support, the answers are sitting in communities, and we really need to lift those up, ask for them, engage with them, be led by them to come up with really important solutions, continuing to diversify the workforce. And also alongside that, to bring more cultural humility, cultural competency to the rest of the workforce as well. And then finally, I think really thinking about and acknowledging not only the diversity of patients, but also diversity of patient journeys, and really engaging with not just a clinical pathway or experience within healthcare, but really what has happened to the patient in their life. So not only what has brought you here today, but what has happened to you, is out really asking these questions so we can holistically support patients with the healthcare that they receive, and optimally to achieve best outcomes.
Great, thank you for that more so. Sharon, was there anything you wanted to add there?
No, I think a lot has already been said, and I know there's a couple other juicier questions that I think I'll be able to jump in on a little bit more.
Absolutely. And thank you each for being transparent and really connecting with our viewers. It's important that we break down the medical jargon into layman's terms, so we're connecting with our viewers and they understand what we're trying to build on as health equity. So here we go. The American Medical Association established the Health Equity Center in 2018, and in 2021 developed a strategic equity plan entitled Embed Racial Justice and Advance Health Equity. What are some ways the science industry can make equity a part of the practice, process, action, innovation, and organizational performance? And I'll start with you, Sharon, because I think that's in your wheelhouse.
Yes, it is. Yes, it is. I was looking forward to this question. And I think some of my comments will also dovetail to the previous in terms of looking at systemic ways we do things. And so for folks that research may be a new topic for them, when we're looking at setting up a topic or setting up a research study and to test a new entity, we need to work with sites, and sites can be hospital clinics, community clinics, a variety of opportunities. And so one of the first places that we really took a long look at is our site selection process. And, and I think referring back to the systemic question, the way we actually identify and select sites may at times stack the deck in the wrong direction when you're looking at diversity and equity. So we've really been looking, and the company took a very public commitment to ensure that going forward, 25% of our US sites will sit in diverse areas. And the way we've defined diverse areas is greater than 30% non-white. We've been looking at using US Census data as well as epidemiology data for the particular indications to really look at how we target and build a process that does bring the studies, the clinical trials to those areas that perhaps have been overlooked in the past. However, we've learned from our early experience that it's not a one-size-fits-all approach, and there needs to be, in addition to targeting and working closely with those sites, you need to kind of, anytime if you're planting a garden, you need to prime the field. So, connecting with trusted community partners in those areas, educating the teams in terms of awareness. And the one thing I think that surprises folks, it's looking at ourselves as well, and how we take a look at our own culture in terms of, my boss is fond of saying, looking in the mirror and really seeing what are our practices that may have a latent approach that doesn't necessarily favor moving in a new and different direction. So working closely with those sites to really cultivate. Also, I think Micheline referenced, looking at our investigators. We've learned that patients want to see a doctor that looks like them, can relate to their experience, can truly understand what they're doing. And so, both within our foundation, looking at investigators that are developing investigators that are more focused in areas of race and ethnicity, but also within our existing pool of investigators, are there ways we can ask to give opportunities to other physicians? And then the last, just to touch on, is innovation. To my earlier comment about needing multiple tools, innovation is another tool in our tool belt, and looking at ways to, are there new and different ways of doing research? With the pandemic, we've heard a lot of decentralized trials, and are there ways to look at bringing trials more close to where patients are? I referenced in my opening comments, access is a big challenge for patients. If my physician doesn't mention the existence of a clinical trial, they could be left without an opportunity. So, both educating our healthcare providers, but also looking for new and different ways to bring access to those further reaching places and create some new opportunities. So I'll pause there. I can keep going on this one, but I want to give my colleagues an opportunity as well.
Sure, we're going to take a breath. Patty, if you don't mind, I'm going to go to Micheline and then I'll come back to you.
Thank you so much. I really love Sharon's answer. So thank you, my fellow panelists. It is precisely the reason why an element of the offerings at NMF also include increasing diversity in clinical trials. So we have a variety of fantastic partners, one of which is the Bristol Myers Squibb Foundation, Patty, that actually provided us with a $100 million grant in order to really build out a diversity in clinical trials effort so that we can increase the BIPOC underrepresented in medicine percentage of clinical researchers and clinical investigators, but also, and this is what really I love about it, how to also create a curriculum in order to encourage them and to teach them how to center community voice, right? And then how to make certain that once they have the access to the opportunity to engage with community members in this way, how do we then also provide them with an opportunity to be advocates for them? Because as you know, Assemblywoman, I oftentimes refer to those social determinants of health as the political determinants of health. And then we have a separate one with Johnson & Johnson and Merck, where we do very, very similar things. And that one aspect that Sharon just mentioned about the incredible missed opportunity to increase participants who are diverse in clinical trials often happens at the point of that clinical interaction, literally because a physician's implicit bias rules them out, not because an individual who's a member of the Black and Brown community has said no, but because the studies show they are not even asked. It is already predetermined that they cannot participate for some other reason. And as a result of that, it's one of the reasons why still addressing that effort of implicit bias is still incredibly important to actually eliminating healthcare disparities. Thank you.
Absolutely. Patty, please.
I just want to lift up one really important partnership that we have here in New Jersey with the Henry J. Austin Federally Qualified Health Center in Trenton. So the great visionary Kemi Ali has a grant from Bristol Myers Squibb Company to look at how she can make Henry J. Austin a place where clinical trials can be conducted. So when Sharon talks about distributing and spreading out locations for clinical trials, safety net settings, federally qualified health centers are really important to engage in this. So she is really playing a leadership role, I think, for FQHCs across the nation in taking on how Henry J. Austin could be stood up and connected with investigators to participate and bring the clinical trial opportunity to her patients and Henry J. Austin's patients in the Trenton area.
Great, and thank you for that. Trenton's also one of our partners, our vice chair of the Black Caucus, Assemblywoman Verlena Reynolds Jackson, hails from that area. So we're always fighting for healthcare access there. Dr. Purnell, before you go, before you share some morsels of wisdom, the New Jersey Medical Association, which is our Black docs in New Jersey, a number of them practice at University Hospital. At the height of the pandemic, before the vaccine was available, they were actually fighting for Black and Brown participants in clinical trials to know the impact and the effects, because we were dying at higher rates from COVID-19. So I can't tell you, it's critical to have people who look like us from the community advocating for us in those rare air spaces to participate and to have access. Dr. Purnell, please.
Sure, there is so much to say, so I jotted down some bullets to keep myself honest, but I'll start first with what first comes to my spirit. Too often, science has been a tool of white supremacy. And because science has been a tool of white supremacy, it has been a vehicle by which to perpetuate a belief that white lives are of greater value. And if those lives are of greater value, you have different access to not just care, but research opportunities. And the notion around willingness to participate is something that we really need to peel back. And so when we talk about inequities, we frequently can frame them in three buckets. Inequities happen because of differential access to care, and put clinical research in that care, because of differential quality of care received, okay? And then because of unfair and unjust access to life opportunities. If those are the buckets, we in the scientific community must own and demonstrate accountability around the systems of oppression, the systems of power that have locked out and have excluded groups and communities. And what we saw, I believe, begin to happen during this pandemic is a more honest assessment of how science has perpetuated medical and scientific racism, a more honest assessment of the work and the accountability of organizations to demonstrate trustworthiness, so that groups who have been marginalized and historically excluded receive signals and cues in the practice and policy and program environment that their humanity is valued and respected. And because of those issues, there is an opportunity right now in science, right? There is an opportunity by one, ensuring that we share power with community, and community becomes co-researcher. Too often, community is viewed through the deficit lens. There is a provider and there is a client, where we need to view community as an equal partner, and we're sharing power with community. Community has its own form of power, and scientific organizations or companies have their own form of power. But when we can recognize that we need the full complement of that power at the table in order to achieve human goals, we're going to see health equity achieved. And that's why I personally enrolled in a coronavirus vaccine trial. I knew that as a public health physician, I knew as a healthcare leader, and I knew as a Black woman who had lost her father. It will be 2 years on April 13th that I lost my father to this pandemic. And as a senior leader in university hospital, seeing how devastating the impact that coronavirus was, especially early during the surge on Black and brown communities, I needed a way to demonstrate transparency, autonomy, and accountability. And science needs to create space. That's how science uses its power, space for that to happen, where investigators are diverse, where communities are invited to the table and they ask the research questions, and then where people feel heard, validated, and seen, so they know that it is safe to participate. So this is an opportunity, and I think we're finally starting to have this level of authenticity in our conversations, and it is this level of authenticity that is necessary. And the last thing that I'll say, it is impossible to practice medicine or impossible to practice clinical research from an ahistorical basis if you want to do right by human people. It's impossible. You got to know people's stories to do right by them.
Thank you for that. And Dr. Purnell, you really rolled us right into our next question, but knowing people's stories, and Micheline, you know this to be true, we have to tell our stories. We can't be afraid to talk to the white coat. Right, we have to be honest about what we're experiencing and not just saying we're fine. I have a mother-in-law who's 80. When she goes to the doctor, she always says everything is fine. Blood pressure's through the roof. So it's a training. Any day they wake up above ground, it's a good day. That's their story and testimony. So we have to become honest and take a partner with us to have these conversations with the physicians, so we can tell the truth about our health and really get the care that we need. And with that, I'm going to start with you, Micheline, to continue along that theme of how can an organization widen its net of diversity visibility across all business segments?
So thank you so much, Assemblywoman. This is such a good talk. I'm being so encouraged. So love the fact that we've had this in the middle of the week. So I mentioned earlier the ability to ensure that we are utilizing racial equity lens as we implement and utilize our anchor mission as institutions and large scale organizations. But there's also an opportunity to also apply a racial equity lens to every clinical, administrative, and operational decision that is made. And I literally just did a talk up in Boston yesterday for a resiliency conference. And when I talked about that, I literally said, that sounds very technical. It sounds very scientific, when truly, right, it could literally be a racial equity assessment tool, which when I first began talking about this 20 years ago, right, I had to give everyone mine. Now, if you just Google, you'll find them all over the internet, quite frankly. For government, I recommend those who have been developed by Change Lab Solutions, and for policy leaders, those from Policy Link. For businesses and nonprofit organizations, I recommend the work of Race Forward, etc. It really gives you an opportunity to have literally a set of 5 to 7 questions that says, who's been historically marginalized, right? Who is not included? How do we make certain that they're included? How do we create, right, what needs to be done in order to make that inclusion actually feel like belonging, right? These are not that difficult a thing to do, but it is imperative if in fact you want to be about that statement that you pushed out last Juneteenth or 2 summers ago, right? And it's really imperative that organizational leaders understand that, listen, your employees, your team members, your staff, they are watching you, everything that you do. So not just a statement, but what the action that's going to follow up, not just a courageous conversation, but what's going to be changed about the way in which you recruit and hire, right? To make certain it's not just outside in, but it's also inside up. How transparent are you about the way in which you promote, about promotional opportunities, about stretch assignments and project championship? Is it something that is open to everyone, or is there a monolithic group of leadership that comes together and decides that they want the folks who look just like them, who think just like them, who come from or share their lived experience, right? When I said that yesterday, a young man walked up to me, a young white male in his mid-50s, and he said, you just described my entire career. Because someone always came to me, tapped me on the shoulder and said, Bob, I like you. You remind me of myself at your age. I'm going to give you this opportunity, right? So I thanked him for recognizing it and then asked him what he was going to do to change it, right? And so this is what I'm talking about. There is a real way to do this. It requires intentionality and inclusive thought. Right? It is as simple as going into a room, looking around the table, and if everyone looks like you, understanding that the meeting is not ready to begin, and stopping it, going outside and getting other folks, not just by title in the organization, right? Because if an organization is monolithic in 2022, trust me, we believe that that's been intentional too. And so as a result, we need to make certain that you're getting individuals who have a different lived experience, have different gender, right? And racial diversity, and bringing them to the table. And ensuring that what you're trying to do is not what is right for all, because that is equality and nobody has time for that. We are looking for equity now. We need for you to come up with a process that literally reflects the fact that historically, certain demographics have been minoritized, right? And then let us make up for that. And so all of this, right? It sounds like a lot, it's not. It is not. It is exactly what I say this all the time. When people talk about the difference in, you talked about definitions earlier, social determinants, political determinants, what are we talking about? It is exactly what Miss Mamie in the church knew, or the neighborhood abuela. They always knew that I cannot be concerned about whether or not I have enough money for my prescription, if in fact I'm choosing between my prescription and feeding my family, my prescription and keeping my heat on, right? So if they knew it, why is it that these large scale organizations with all of our academic careers do not? It requires a willingness, a small p political willingness and true intentionality. But I guarantee you this, it can be done. And your team members and your staff and those who report to you, they know it.
Amen. I'll send my offering in at the conclusion of this seminar. Patty, you're up.
Always hard to follow Micheline, you know. It is so much about mindset change. So at Bristol Myers Squibb, if you come into our company, you will see everywhere the question, who are you working for? So our health equity question is, who aren't we working for yet? How will we see who we're not working for and then make our way to them, partner with them so that we see everyone and we work for everyone across the life cycle, whether it is in the clinical trials and in the access that we have in delivery of our medicines through our partnerships, every corner of the organization. Who are we working for? Who do we need to work with? And who are we leaving out? And let's stop that. Let's see it and build it into everything we do. And just an intentionality, as Micheline was saying, is that there are 1,000 opportunities a day to address this. It's one small action after another. So changing the mindset. The other thing that we've been doing is just educating folks about health disparities in the very disease areas where we work. So for example, lung cancer, African-American men most heavily affected by it. We can go through all of our other disease states. Multiple myeloma, African-Americans 2 to 3 times more likely to have multiple myeloma than others. So just taking that kind of information from general epidemiology to let's really understand the subpopulations affected by our diseases and make sure that we're being inclusive in our approach to them. A couple other things that we're doing. Micheline talked about in and up. One of our diversity and inclusion commitments is for the executive level. So bringing gender parity to the executive level and also African-American and Latino colleagues at these tables. And those are the power tables. That's where strategy, resources get directed, new initiatives, quality improvement, new kinds of innovation. So to have diverse lived experience at that table is so important, and really looking to see over time how that changes who we are at BMS and what we're able to deliver to patients. The other thing is just relentlessly looking at what is another lever we can pull. Certainly supplier diversity and just using our buying power to drive equitable economic development. In communities, we joined the $1 billion commitment to buy $1 billion around the world from diverse suppliers by 2025. And for our supplier diversity team, this is not just about the spend and the contract for procurement itself. There's also technical assistance to help those diverse suppliers to build their businesses in partnership with the Tuck Business School, for example. So to be a partner is not just about we're doing business together. It's also, I want you to win and to push forward in your business as well. And that's very much the mindset that we've adopted on that front.
Awesome, truly remarkable. When you talk about the power table, I often think about how we play politics, and this was mentioned a couple of times. At the height of the pandemic, again, Legislative Black Caucus was called upon to elevate and amplify what we were hearing in the communities and what our needs were. Multifamily dwellings, we couldn't quarantine, our students didn't have equipment, broadband access to do remote learning. So really making sure we highlighted those needs back to talking to the abuelas, talking to the nanas, and making sure that Pop knew how to FaceTime so he can check in with that teacher. It was critical that we brought those stories to the power table to make sure funding went in those buckets to address and redress the harms that were being caused because we had to shut down for health safety. Dr. Purnell, I don't know if you want to add anything in that space with the work that you do.
Definitely. I just want to add something about first the concept of creating and driving diversity within an organization. And this is a part of our strategy at University Hospital. Too often organizations seek to achieve equity by having different people sit at the table, when sometimes the table needs to be destroyed and it needs to be rebuilt with the thinking and the enterprise of the different voices that are represented at the table. And we need to ensure that people have resources to achieve success and have pathways and lanes to build upon the achievement of their appointment or opportunity in and of itself. And so that was very evident in how my very role was created in the organization. I was not interested in being a chief diversity officer. I was interested in being someone who could leverage health equity across multiple business units in an integrated fashion, from strategic planning through our population and community health and patient and human experience. And I say that because that is the lens with which we're looking and pushing equity, not just within our ecosystem of an organization, but across multiple anchors and across our geographic region, right? And I think in this level of accountability and transparency that we have, that we look to do those things, because too often Too often. I've walked into rooms where I literally have had conversations where people's like, oh, we've done it. We've achieved it. Look around this table. And everyone around that table doesn't have the same power. That table is still structured by policy and practice confines that don't allow it to operate with intentionality around equity. And everyone doesn't have access to support and resource and development to sustain progress, and progress can become transformation. And the last thing that I will say with that is on this idea, I've been sitting with this notion of a pendulum, and what I don't want to see happen in this very pregnant, ripe, and poignant time is that we get satiated by progress, because progress is a pendulum that swings forward and then swings back. We need to break the pendulum. That's transformation. And those are the new thoughts, the new ideas. And that goes back to that idea for how do we share power? How do we share power? And power is decision-making authority where possible. Power is driving local economies. Power is the sharing of distribution of resources. And that's the level of intentionality and strategic imperative and willingness that I believe we have to get to.
Great, thank you for that. Sharon, if you can just add a little bit on how you see the room, leadership and research for optimum participation and enrollment for the advancement of medicine in your organization.
I think one, certainly looking at how, how we do research and looking at ways, are we designing studies with a broader population in mind? There have been studies that have shown that the very clinical trials that we seek to recruit diverse populations often exclude those populations. So looking, for ways to design a better clinical trial that is more inclusive. And one way we've been looking at that is looking at our inclusion and exclusion criteria. Very often clinical trials have very lengthy lists of criteria that in a lot of cases exclude patients. So looking at whether it's particular lab data or certain standard of care medicines that, back to the point of access, patients don't always have the same access to those medicines based on either their insurance provider or their physician, based on what they're actually being treated with. So looking at that criteria to see, can we do a better job of designing a study, be it adding smaller cohort groups within the study that are in some cases all comers, to make it a bit more of an open opportunity from a clinical research perspective, but really looking for ways to. I liked what Dr. Purnell said around rebuilding or tearing it down, and we're trying to do the same with our clinical trials. Sometimes it's breaking a lot of those long-standing approaches to things, but I agree that sometimes the build anew is often much more of you end up with a broader, more inclusive approach. So just looking for ways to think about things a little bit differently, change our mindset to really think with a broader lens.
Thank you for that. And I will tell you, when it comes to building trust, part of what we've done as a legislative Black caucus in the foundation was really partner with the different healthcare systems and providers to build trust, because it was important that we received help, continue to have care for existing health conditions that went untreated during the pandemic. So we really worked hard in promoting telemedicine as another avenue to stay connected with providers. On the legislative side, we fought to make sure that funding and reimbursement was there as well in that space, so people wouldn't miss critical appointments. And then, of course, as you heard earlier, New Jersey stood up its own healthcare exchange because we needed to be sure that people who were losing jobs or were earning less and struggling with unemployment, trying to get through that portal, that they still had healthcare availability in a form of payment for their health care so that care would not suffer. Still a long journey for us, but nonetheless critical connectors to make sure that we were supporting the health of our entire state. And I will punt this to Patty. How are you creating a safe space to provide employees with the resources and education necessary to prepare and safely report for systemic and structural racism?
There are a number of components to this at BMS. Certainly our overall diversity, equity, and inclusion training that is going on for all employees and also for managers. There is consistent surveying of our employees in terms of how they're experiencing diversity and inclusion at work. So we have that tool as well. There's manager training for taking in employee reports in terms of microaggressions or other kinds of incidents of discrimination, as well as our ombudsman and our D&I office as well. So we are strengthening those pathways to bringing these incidents to attention and having them properly addressed, while also working across the organization to build a culture of awareness around the importance of reporting these things, but also doing preventive work as we look to become a more inclusive organization and really have broad, very deep awareness of what microaggressions are, how they are experienced by people as well. So multiple parts to it at BMS.
Patty, I'm just going to ask you to break down microaggression. I'm often asked that question. What does that mean?
Yeah, I think microaggression for me, and as we talk about it at BMS, is really coming into a room, for example, and sitting down and talking to everybody else, but perhaps a person of color. So you're not doing anything overtly. You're not saying, I'm not talking to you, but just coming into the room and just ignoring the person or not bringing, including them would be an example of it, or passing over somebody to tell them about an opportunity that might be within the organization could be another one that could have very important consequences. So that's the other thing, is that it might be called micro, but it can have very, very big impacts on the person individually at the moment, emotionally, but also broader implications for them as well.
Thank you for that. And just to reference the political table, we were doing a lot of work putting these policies and mandates on the public sector. We talked about the 2020 civil unrest with the senseless killing of George Floyd, making Juneteenth a state holiday in New Jersey first, and the federal government followed with making Juneteenth a federal holiday, but recognizing that as state legislators, we were not requiring training on implicit bias for elected officials. And New Jersey has some of the most segregated zip codes in the country, while we're a diverse state. So I'm proud of members of the Legislative Black Caucus who elevated the need for us to be mandated to have the training as well, so that we can also be a part of the change that we're mandating on all sectors. Dr. Purnell, I know you have some words in this space.
Sure. Just to piggyback previously on the question about creating safe spaces. So structured under my office, for the first time, we are building out an equity and inclusion department. And there are a few hospitals that are leading in this area across the nation. Out in San Francisco, Zuckerberg General is an example of another. And this equity and inclusion department, literally at a senior level, has someone whose job is only tasked with looking through an equity lens across all operations in the organization, looking at strategic goals, looking at departmental goals, looking at the tactics to achieve those strategies and goals. And we have assumed a larger scorecard that you can accumulate those metrics and processes across. Knowing that we're doing that creates a safe space for people to own the truth of their narrative, of their experience. So we talk a lot about the human experience at University Hospital, the Barrow Institute. which is the premier organization around patient experience, has challenged healthcare and all of those involved in care more broadly to think about the human experience, right? So workers, patients, families, and communities, not in silos, but as interconnections, interrelations, and interdependencies. So we're creating vehicles to capture voice, right? Or to collect voice, whether it's our community advisory council, because our boards are appointed by the governor. So a community advisory council that can have more transparent and authentic community input, whether it's our patient and family advisory council seeking to revitalize that. So we understand through the diverse and inclusive voices, what is it like to receive care here? How are employees or workers able to report when they have experienced bias or aggression in the workplace? And what are the policies that we examine to undo the environment that allows that culture to continue to exist? And so I think creating a place where people can belong, and this is what Micheline said earlier, is a stepwise, it is a matrix type of approach. And that in and of itself is what ultimately creates a culture of safety. Because if I can't belong there, if I can't show up with my whole identity, then I'm not safe. I'm not safe. I'm not safe. I'm not safe in how I'm evaluated in my performances, because I wanted to challenge our notion of safety. I'm not safe in how I'm evaluated in my performance evaluation. I'm not safe when it comes to those stretch assignments. I'm not safe when it comes to leadership development. I'm not safe when it comes to opportunities for me to demonstrate what I can add to the organization, because I'm not safe to thrive. And so we at University Hospital are constantly thinking through that human experience lens, workers, patients, families, to challenge ourselves in creating a roadmap to equity and I would say resting that in specific metrics, right? So metrics that are assessing our culture. We did a cultural competency assessment for the first time as an organization. We did a 360. We asked patients, how fluent are we at dealing with cross-cultural conflict? Do you feel like you are heard, listened to, and spoken to in languages that you prefer? And using that type of information alongside a worker data assessment, where we can have hardcore concrete numbers to say not just how people feel or what they perceive, what does the data also show that is happening? That drives safety. If it's not an organization where that multiplicity of action and efforts are happening, then you hear from people, well, I can't tell you fully my experience because it could be a retribution, or there really isn't an opportunity for me to use all of my credentials. We even had on our governance committee, we have a E&I governance committee. We have design teams. We are looking at promoting equity champions, like wellness champions in the organization. And I will never forget this feedback. A Black woman says to me, has the organization considered how well credentialed Black women are here at the hospital, but they're not in positions where they get to utilize their credentials? That's where you're safe. When you can be seen fully in your capacity to add and to help transform.
So I'm going to ask you how you define microaggressions as well.
I don't use the term.
Okay, and tell us why.
There's nothing micro about it. Whether it was, and I can give personal experiences. I remember being in medical school, and for others it was a joke, but they're like, "Oh, Purnell, how did your family make it up from slavery?" Right? And I'm like, up from slavery in the middle of a surgical case, right? So some would say, "Oh, that person was just attempting to infuse humor." But you're attempting to infuse humor by focusing on an overtly racist past, an overtly racist institution in slavery, where there are still long-lasting and legacy effects from it, and we haven't transformed our society, and in an organization where the department chairs are predominantly white men. So it was communicating to me as a Black medical student, it's not safe here. You can be belittled here. Your accomplishments and your value are not equivalent to someone else. And so by those personal experiences, that's just aggressive behavior. And so I oftentimes talk about the difference between assertive behavior and aggressive behavior. Assertive behavior is where you can advocate for your own rights, but you don't usurp the rights of someone else. Aggressive behavior is where in advocating for your rights or expressing your views, you are usurping my rights as well. And oftentimes those microaggressions, as people call them, are usurping the rights of another person. And it's usually the historically excluded or marginalized person.
Right, thank you. Thank you for that. Micheline, I see you nodding your head. I'm going to ask you to weigh in, if you will, please.
Absolutely. I'm so delighted that we've literally put this on the table. I say all the time, listen, I call them macroaggressions, right? And sometimes, right, and I appreciate trauma informed language, I do, right? And so that's why we have microaggression, macroaggression, micro assault. Nothing is micro about them. And so that's why I always talk about the fact that it is macro, right? I distinctly recall being in a meeting and having someone come in and grab, like literally palm the top of my head. And it was because, right, this is just blown out, but I have this lovely, beautiful curly afro that I hold up in a bun. And literally before beginning this meeting, they were like, is all that your real hair? Right, so this is the meeting that I am set to chair. And this is the greeting by the white male who walked into it. Right. So if I have that on the table, and I have the many times when Assemblywoman, you recall when I was actually the acting state treasurer, and how I would walk into a room to begin a meeting and people would look at me and literally say, we're going to wait for the treasurer to get here. I am in the room. But because of the fact that my reality actually flies in the face of your bigotry, you cannot see nor appreciate me, because I show up in a package that you do not anticipate intelligence to be packaged in. Right. And so when we talk about this, I don't use the terminology microaggression either, because when in fact it occurs, it scars the other person deeply. It is literally an element of racial trauma. I once said to a racial trauma specialist that I had experienced some, and then began to talk about it. She stopped me and said, actually, Micheline, you have experienced racial violence. It is more than just having a trauma experience. And so despite the fact that the DSM-4 does not literally list racial trauma as separate from the PTSD categorization, we, each and every one of us, know and understand. And I pray really that we will begin to see this formalized in the industry dialogue. And that is the fact that racial trauma is so complex and that it really does stand on its own. And that is one of the reasons why, right, I too do not utilize the term microaggression, because when you have been on the receiving end of it, there is nothing micro about it.
Thank you for that. And DSM-4 is what they use for the diagnoses for all of the psychiatric terms that are listed. And there's thousands of them. PTSD, post-traumatic stress disorder, again, terms and initials that we use. And we're often taught as a Black woman in mental health for over 20 years to overlook those occurrences and to keep pressing forward. The church has been a big part of the healing process and of providing dignity and respect to African Americans as they go through a hard week of battle in these spaces to make elbow room at the table and to command space. But not only was Micheline the first African American woman treasurer, she was also the youngest. So she had, the trifecta happening in that space, and often in many spaces where she's walked into. So again, being conscious of that and how we start to change the narrative, that's the trust that we're trying to build here. And that's really the safe space that we want to have this conversation. And so I thank you all for being candid about these realities as we look to change the pendulum. I think that's what you said, Dr. Purnell.
I want to break it.
Break it, forget change. We're breaking it. We're breaking. Just break it. So I'm excited about moving into that space. So I just, want us to think about, as I was on a couple of other webinars this week, job descriptions. And as we talk about creating a culture of diversity, amplifying diversity in our spaces and equity, challenging the wealth gap in New Jersey, one of the wealthiest states in the nation. how do we, and how are, some of your companies working with the job descriptions to bring in employees and to allow for that pathway to thrive as we come out of this pandemic? And I'll start with you, Patty, in that space, if you don't mind.
Sure. Thank you for the question. So Bristol Myers Squibb has created a partnership with 5 HBCUs it's called Tomorrow Innovators. And it is a program to talk to students, not just that are interested in the sciences, but all of us around the table have very diverse from academic program backgrounds. So students in sociology, students in political science, as all of the assembly people here can very much appreciate the importance of that as well. Really looking at what is all the disciplines that really make healthcare go and health to be achieved for population. So this Tomorrow Innovators program is looking at bringing this, just educating and creating opportunities for students at the HBCUs to see what healthcare is about, not just at Bristol Myers Squibb, but also beyond. But as part of that, we're also looking at those early jobs, right after college. A lot of the healthcare requires advanced degrees, where you might lose folks who are going to do a great job if they could get in earlier, just to explore the area. So paying attention to that is a cadre of worker, an employee at BMS that we can open more doors and create more opportunity for, as well as summer internships and other kinds of programs as well.
Awesome, thank you. Sharon, is there any room for job description changes in your space and the clinical trial and research?
Absolutely. I know when I first started at BMS, we seem to have within the clinical trial space, folks were physicians, nurses, or bench scientists. And I think to Patty's comments, we're seeing the value of that infusion of diverse backgrounds, people who have very different perspectives, but able to take a more project management approach. We're also looking at how do we enhance diversity? And there have been some campaigns that have focused specifically on bringing potential employees of color into the company. We've also, we work closely. BMS has a thriving program of employee resource groups that also focus in many of the racial categories, as well as disabled, LGBTQ, and others, to really ensure that we've got that baseline of cultural relevance, and to bring in those experiences, and a lot of the great comments that I've heard from both Dr. Pinnell and Micheline, really looking at how do we reflect that as an employee body at large. So for sure, bringing in more and varied backgrounds.
Awesome, thank you for that. Dr. Purnell, did you want to add to that?
Sure. I'm constantly faced with an evolving public health and population health landscape. How do we remove and limit the barrier that bureaucracy creates in trying to define new roles, right? Okay, so if equity is customized tools and support based on need, then I have to have new roles to help people with the needs that they have. And so an example of this is community health workers, and how you write a job description for a community health worker. Unfortunately, we too often value their lived experience or the role that they perform in a lower rung. We just do. And so they don't earn as competitively as they should, when they are a critical linchpin in building trust, a critical linchpin in care navigation and care coordination, a critical linchpin in understanding that organizations are socially and culturally fluent. So I've had these conversations in HR around how do we substitute credentials for lived experience, and how do we evaluate skill sets, because some of those skill sets are not traditional. And unfortunately, bureaucracies can sometimes perform like dinosaurs. And we know what happened to dinosaurs. We must become more agile. crises demand of us agility. Crises create VUCA environments. It's volatile, it's uncertain, it's complex, it's ambiguous. And you convert that into opportunities where you can have vision and you can have understanding, you can have clarity and agility. And this area is a space that deserves more attention. And that's why, as a part of our strategic imperatives around equity and inclusion, we look at our team leaders and our colleagues and our peers, and we look at our policies and our procedures. And part of those policies are how we write job descriptions and how job descriptions can be modified and changed, and who are the decision makers that need to be implicated to do that.
Thank you for that. Ms. Shalane, please.
So thank you for that. I think one of the really important elements here is taking a look at two things in particular. One, there really are efforts that you can bring in people in order to take a look at the language utilized in your job description to see whether or not it is inclusive. Quite frankly, there are certain phraseology that oftentimes causes individuals who are BIPOC from BIPOC backgrounds, which is Black, Indigenous persons of color, to not feel welcomed enough to even apply. And so really taking a look at that is one key element. I think a second key element is to really re-examine what we're saying are the requirements of a job. And I say this because when I literally orchestrated this process at my prior employer, some of the things that we looked at were whether or not the job itself really required the educational description that we discussed, right? So I'm not really certain that a file clerk needs to have a master in library science, little things, right? And so like re-examining this, actually understanding that there is a historical wealth and educational gap in this country. And that as a result of that, if in fact you are really committed to doing this, do you have to lower your standards? Absolutely not, but you do need to revisit them through a lens that actually acknowledges the reality of the country, right? And so that's a key component that I really like to make certain that people are welcome to. And then love the fact that Patty mentioned the partnership with HBCUs, right? Please, please, please really ask your HR department, what does your recruitment look like? What form does it take? With whom, right? To whom do you go in order to recruit? So if in fact all you do is go through SHRM and or others, you're going to really begin to understand the issue and impact of the fact that there are specialty associations which could be utilized in order to attach to, right? So if you're recruiting for healthcare, please go to NASI, the National Association of Senior Healthcare Executives, because it is the Black organization within healthcare administration and operation, right? There are, if you're looking for finance individuals or accounting individuals, please go to NABA, the National Association of Black Accountants. If you're looking for lawyers, please go to the National Bar Association, the country's largest Black bar, or to the Hispanic Bar Association. I'm a member of both, right? Because si se puede. And so as a result of that, I just want to make certain that folks are conscientious about what recruitment looks like around those job descriptions. And quite frankly, are your job descriptions also translated into other languages, right? Make certain that we're thinking about a way to not just be inclusive in the initial aspect, but also make certain that you bring all of that, you pull it through to your onboarding.
All right, sorry, I was caught up. So to those in the viewing audience, a couple of things. There's not many questions in the Q&A. There are a lot of comments in the chat. Folks are really loving the transparency that we've added. We've also included a poll, so those viewers, please make sure you respond to the poll so we have feedback on future webinars. The Legislative Black Caucus Foundation also has a paid internship program for college students. So Chairwoman McKnight, before we conclude, will speak to that program. We recognize that as students of color, it is very challenging to take an unpaid internship. When you are first gen, when you are struggling to make ends meet for your family and also trying to pursue a degree at any level. So we wanted to put our money where our mouths are and really create opportunity in the policy space for future leaders of color in this space. So we have a paid summer internship through our foundation. So please, we'll put the website for the foundation in the chat. I'm also going to reiterate the fact that We are going to make sure you have some website links, so that will be in the chat as well for you all to this fabulous panel of resources. I do want to personally thank them for the morsels of stretch assignments, for breaking the pendulum, biodiversity programs, which is a game changer in the supply chain industry to have minorities participate. We've been working on this in the state for over 20 years to break into the procurement process for minorities and not being subcontractors, but the primary contractors in this space. And we're hoping to do the same in the healthcare innovative space, as we are the pharma capital. We also would like to are we breaking the power table too? Flipping it over, canceling it, getting a new one? What are we doing, Dr. Purnell?
All of the above.
All of the above. So let's create some new power spaces and safe spaces where we can raise our voice and bring our whole self. I can tell you, as a legislator, healthcare professional, I had colleagues who really want to separate you into different people. I'm also a mom and a wife, a community leader. All those hats I wear at one time. If I start trying to be different people, it's called schizophrenia. And I try my best not to be in that space, but really to represent my whole self, bring my whole self to everything that I do with excellence, but also making time to rest, because that's also important. And then focusing with intentionality, and we heard that here today too, on the change we want to see, because post this pandemic, we have to do things differently. Too many people of color are dying prematurely because of comorbidities, because of stress, because of under representation in the healthcare environment and having access to healthcare. So these are all the things that the Legislative Black Caucus has been working on for decades. You heard from the Director of Region 2 from Health and Human Services for the federal government, that over 20 million people now have healthcare because of Obamacare, as it started out and then moved to the Affordable Care Act. And New Jersey has also provided healthcare through our exchange. We support our hospitals, we support innovation, and really could not do it without some of these leaders here leaning in their respective spaces to see the change that we need to see. So as we begin to wrap up, I'm going to start with you, Patty, for final remarks that you would like to leave with our viewers today. And thank you for staying with us through this awesome panel and our first virtual series.
Thank you so much. I'm just grateful. I mean, my heart is full having spent time with all of you. And I'm so inspired to bring so many of these gems forward back to my organization. I have my marching orders on at least 10. I'm going to go bigger than 10 though, for sure, on these things. And just make sure that this community knows that Bristol-Myers Squibb stands ready to partner and to learn together and to really move along this journey, but with a sense of urgency. As Assemblywoman Sumter said, people are dying. People are experiencing illness that they don't need to experience, and that's taking from other parts of their lives as well. So we're here with you and really want to bring our best resources to the table and all that we can do, and definitely learn from you all and partner optimally for Black communities, Black and brown communities in New Jersey.
Thank you. Sharon, please.
No, thank you. I'd like Patty. This has been a great conversation. I've learned a lot. Like Patty, I was taking feverish notes to bring back. But I think just to echo one of Patty's themes around, collaboration and partnership, we recognize that, we can't do this alone. And certainly, as we're looking to build more robust and balanced clinical trials, we need to be working with other people, looking partnerships with sites, partnerships with trusted community allies, partnerships with patients and caregivers. I think we often overlook the caregivers, the wives that are pushing their husbands for prostate care or cancer follow-up, the aunts or the nannies that are really, encouraging family members to seek care and don't always listen sometimes, but looking for ways to build that awareness into how we embark on clinical trials, and making sure that I think ultimately one of my selfish goals is that clinical trials are part of the healthcare landscape, that they are a care option for patients going forward. So really looking forward to partnerships that continue to build that better health outcome for patients.
Thank you for that, Sharon. Micheline.
So I so appreciate this opportunity to be here with these absolutely brilliant minds and who are intentional, right, and open, and I really enjoyed this. Patty and Sharon, I fully intend on making certain that we figure something out together. I think it's fantastic to meet more disruptors in the field. To all of the audience, I want to thank you so much, not just for joining us, but for staying with us, and understand that you actually give us the impetus to keep doing this work. Health equity work can be taxing, right? And so it's really keenly important that we do so. I really want to encourage folks to think about this as they depart from us. We talked a little bit about the job description process, and I mentioned something about onboarding. Organizations are really good about having recruiting interviews and then exit interviews. I need for you to take a look at the importance of stay interviews. And I say that because of the fact that, right, we oftentimes see the fact that organizations tend to have a higher turnover of BIPOC individuals. And you have got to be able to make certain that you're speaking with them frequently in order to very clearly ascertain where are the bumps in the road of the design process that you've already orchestrated, and how can you work together in order to fix it? Understand this, it's not their job, right? And so we want to make certain that our efforts around belonging are actually truly inclusive. Do so before they leave you.
Great, thank you. Dr. Purnell.
Just to echo everyone's sentiments, really, really grateful to be a part of this panel, to be with two of my favorites. I've been with Micheline and Sharon before. It's always a great conversation. I know it's always going to be some firecrackers that go off. And Patty, it was awesome to meet you. And what I would leave people with is we must get more comfortable with power dynamics, power assessments, and power asymmetries. Because if we can't have open conversations about power, then we can never achieve health equity and we won't arrive at justice. Because again, racism is a system of structuring opportunity whereby certain individuals and groups are unfairly advantaged, other individuals and groups are unfairly disadvantaged, but the strength of the whole society is sapped. And so if we always keep that before us, then we must look through a power lens and diagnose appropriately where's the power in this situation. And the flip side of that is accountability. Organizations, institutions, business, government, we must get more comfortable with living accountability by sharing power and how power can be shared in different dynamics. And finally, I want us to be comfortable with healing. In healthcare, there still isn't congruency always with healing. And healing is more than superficial, it's transformative work. And we need some healing. That's why I began with the Dean, Dana Bowen Matthew, who talks about hospitals as hubs of racial, yes, Micheline, as hospitals as hubs of racial healing. I remember being in the room in the American Hospital Association. She put that question to people and they were like looking to the left and the right. And so I challenged myself around creating that healing environment within our organization at University Hospital. And I would hope and pray that all of those of us participating today, that we will begin to carry forward that healing and justice work.
Great, thank you. Thank you for those diamonds, pearls of wisdom. Please, viewers, continue to complete the poll. At this time, I'm going to turn it back over to the chair for the foundation, Assemblywoman Angela McKnight. If you can join us now for some closing remarks.
Here, just waiting to put my camera on. right, there we go. Hello, hello. Wow, what a fire day. I wrote my notes down. Micheline, what did you say? If everyone looks like you at the table, you need to have more people at the table with you who don't look like you. Patricia, great program, Tomorrow's Innovators program at the HBCUs. Sharon, change your mindset. That's what you said. Be intentional. Dr. Purnell, how do we share the power? Yes, those are all gems that I wrote down, and I know everyone who's still listening, you wrote down more too. Now, in the beginning, I gave you a charge to go and tell at least 10 people. Patricia says she's going to tell more people, to go and tell 10 people about what you learned today. But before you leave today, I need for you to write one word in the chat about how you feel about this particular event that we were on. So go ahead and put those chats in, those one words. And then I want to just let you know about our internship program. It's an 8-week program from June to August. If you are a college student, or if you know a college student, you tell them to go ahead and submit their resume to tdd56@norc.rutgers.edu, and we will put it inside the chat. And submit your resume and your cover letter by May the 2nd. We only have 10 slots, but you know what? As we are growing and growing, and as you are filling in some donations to us, we will be able to give more people this opportunity. And this internship will allow interns to work with assembly people and senators on how a law is processed, how we build a law, how being at the table and getting briefings and helping us move forward in New Jersey. So it's a great opportunity. I have had an intern. I know our chairwoman has had an intern, and we love it because we have one intern who went through our program, and he is now the chief of staff of one of our colleagues. So it's a beautiful program. So please, 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 go in and submit your resume. And I see all the powerful words that are coming in on this chat. And I want to thank you on behalf of the foundation and the caucus. Thank you for being with us today. And we look forward to having more events such as this one so that we can continue to educate our community and move forward in the state of New Jersey. Let us continue to be the leader that other states follow with this health equity. Thank you so much for allowing me to be with you all today.
All right, thank you, panel. We're going to put a couple of more resources in the chat. If you all have links that you want to add to the chat, because we have a diligent audience here. And then we'll make sure they're on the Legislative Black Caucus Foundation website as well. But truly, thank you for your time and your commitment in the respective fields. Enjoy your day. Blessings.